This meeting is being recorded.
Good evening, everyone. Very warm welcome to this webinar out of the box, Fit for the Shift, aimed specifically for young trainees, hosted by a new team of the CSF panel, the young panel. I'm really, really happy. My name is Katharina Wolf. I'm a neurologist in this team, coming from Freiburg, and I will host you together with Torbjørn Jensen from Copenhagen. Warm welcome to you. And also with Mukesh Shah, a very, very experienced neurologist, our head of hydrocephalus care in Freiburg as well. And we are so happy that there are still members connecting to the webinar currently. So I'm just taking my time babbling here a little bit longer so everyone can actually join and hear from our experts who will share their experience of hydrocephalus and what to do, some very nice basics and some insights for you, so you're better prepared for your first on-call night. I am here also to remind you that you can put your questions into the Q&A section. So you see at the bottom of your screen, there is a Q&A section. Please use it, put your questions in there, and we will collect them and put them to our experts so you get an answer within the webinar live while we are here. Please don't use the chat. We will check that as well, but the main spot for your questions is the Q&A section. And with this, I'm happy to give the word to Torbjørn, who will introduce his chair. Thank you.
Yeah, so thank you, Katharina. Yes, I'm very honored to present my own professor, Marianne Juhle. She is a professor at the two largest neurosurgical departments in Denmark. She's done a ton of scientific work, especially on hydrocephalus. She's subspecialized in hydrocephalus as a neurosurgeon. And at my facility in Copenhagen, she's one of those consultants handling the most difficult hydrocephalus cases. So welcome, Marianne.
Thank you, Torbjørn. I just had to unmute myself. Let me see if I can share my screen, or will you do that, Anna?
You can just share it normally now.
All right. Let's see if it works.
Mm-hmm. Fantastic. It's perfect.
It works?
It works.
Okay, fine. Thank you. So this is the title that we were actually given, Foundational Principles in Hydrocephalus and What to Do at Night. And while preparing this presentation, we could almost as well have called it What Not to Do at Night, but we'll see. Yes. I don't have any disclosures except this, that this presentation is meant for junior neurosurgeons and trainees, so it's basic, absolutely non-sophisticated information. So if anyone feels, that this is too basic for them, they are of course free to leave, but this is what you should expect. It's only core knowledge, what everyone should know, regardless of level of expertise. The goals have been specified to identify and differentiate major forms of hydrocephalus, understand various treatment strategies, including individualized adaptive approach, and to recognize common signs of shunt dysfunction or treatment need. So we'll go along with that and see how we do. So the agenda for this is to define some key types of hydrocephalus, review essential imaging, outline basic shunting principles and highlight common pitfalls, and offer some practical guidance on what to do and maybe what not to do in urgent settings. I will do the pediatric and adult bit because Professor Watkins will be dealing with INPH and IIH, and I won't touch upon these issues at all. So from this point of view, I will be talking about newborns, older infants, children, and adults. So infants, they can be either newborn or older infants, and the newborns can be either premature or full-term babies. So in terms of hydrocephalus, premature babies are usually the ones with IVH developing bleeding from a primitive structure called the germinal matrix lining of the ventricular system, giving rise to ventricular hemorrhage in these children. These infants are also prone to infections, pre or perinatal, and that also can give rise to hydrocephalus. It's a bit different for the full-term babies who can have aqueductal stenosis or other malformations which can be cystic hydrocephalus because of genetic conditions or intrauterine infections, and some of this can be recognized already on intrauterine fetal ultrasound, as is seen on this very nice image of an intrauterine case of hydrocephalus. In older infants, you can actually see that there's a lot of common ground between full-term babies and older infants, and it probably means that for older infants, they have actually a hydrocephalic component already as infants in the neonatal period, and the symptoms then develop later. But there are some conditions that do develop later, like benign external hydrocephalus and unrecognized perinatal bleeds. So the findings, which is, regardless of the underlying cause, these findings are almost the same for everyone. There's always findings like a bulging fontanelle and a large and increasing head size. And there is often, but not always, a prominent forehead, prominent scalp veins, and a downward gaze. And the symptoms or the observations that you can have is irritability or crying, particularly when you put the baby down, which is called postural worsening, and feeding problems. And why do they have this? Well, infants can't describe that they have a headache or nausea, but these symptoms are probably the observable signs of this kind of discomfort. You have to be aware that in the premature infants, the signs can be very subtle and very immature, so that these kids are floppy, weak, have color change and respiratory and circulatory problems as a response to untreated hydrocephalus. And it can be quite difficult to know what is going on in these babies. So what to do? Well, actually, here are some, shall we say, good news, because these babies have unfused sutures. They have a soft skull. It means that the head is very compliant. We can almost call that external compliance, meaning that the pressure forces are, it will enlarge the head, which means that the pressure on the brain itself is less, and a lot of the force is used to enlarge the head. And this means that the situation is rarely an emergency to relieve the CSF pressure. It means that you rarely need to be in the middle of the night with a need to relieve the pressure on these infants. There is time to think, there's time to get senior advice, and there is time to observe. And it's also necessary to know that premature action in babies usually carry consequences for the rest of their lives. So it's actually good to have time to think, and you're very infrequently pressed for time in deciding what to do. So are there situations where there is actually an emergency needing acute neurosurgical action? If there is a decreased level of consciousness that you can't arouse the baby, sometimes or often alternating with irritability, that can be an emergency situation if the child is in opisthotonus. And I've put inconsolable crying in brackets because that can also be at a point when you actually need to do something acutely about the problem. So what kind of emergency procedures do we actually have? Well, fontanelle puncture can be indicated in these situations that I was just talking about, but as I said before, it's very rarely needed to do an emergency release of CSF pressure in infants. Before you put in any kind of temporizing measure like an EVD, like an Ommaya reservoir, like a subgaleal shunt, think twice. These procedures carry a really high risk of infection, and it is also said that they carry a propensity to create a situation of shunt dependency. Think again before you put a shunt in, because you may create a lifelong shunt dependence and again a high infection risk. Sometimes it is an alternative to do an endoscopic procedure, for instance, in bleeding or infectious situations where you can actually do a lavage of the ventricular system, and there is increasing evidence that that can actually decrease the need for later shunt dependency. So usually in these situations, you have time to think, you have time to consult, and what do you use the time to think? Well, actually, there are a number of repetitive, non-invasive options that will tell you whether this situation is getting out of hand or whether it is getting more and more stable. And some of these options are actually pretty simple, like measuring repeated measurement of head circumference. Very often in infants, you will find that the crossing of percentiles, like as is shown here, is followed by a flattening off, where the child follows its own curve, and the head increase is wearing off. And if you find that situation and it's followed by clinical stabilization, I think you'll be happy that you didn't do anything in the acute setting. Additional help you can get from ultrasound through the fontanelle, where you can follow, for instance, IVH, as you've seen in this picture, and you can see if the ventricular system dilates and becomes out of hand. The same thing for benign extracranial extracerebral hydrocephalus, where you can see whether the subarachnoid spaces are enlarging or not enlarging. You can also observe the ventricular system. These are non-invasive, easy procedures to follow up and can take away the pressure from feeling a need to do action in these children. Of course, you can use radiological imaging also, but these are these are time points and not as repetitive as the other measures. But you can see the causes of the hydrocephalus. For instance, like in this case, you can see an aqueductal stenosis, probably because of a malformation of the aqueduct. You can see whether there is a multi-compartment hydrocephalus with cysts in and around the ventricular system, which of course, if you need it, needs treatment to address unifying these compartments And you can also see if there are malformations resulting in an abnormal appearance of the ventricular system, like this case with the corpus callosum agenesis, giving this typical H or bat-like structure of the ventricular system, and which can sometimes, but not always, be accompanied by a hydrocephalic condition. So switching from infants to children, the difference between infants and children in the hydrocephalus setting is that kids have a fused skull and they have a hard head that is non-compliant, and you have verbal contact with them, which means that the older the children get, the better they can describe the symptoms, and even small children can complain of headache and discomfort. Because of the fused skull, they now also have more typical symptoms of elevated ICP, which is easier for us to diagnose, but you also have cases of atypical symptoms. So the typical symptoms of elevated ICP, if they are severe and obvious, and we all know the symptoms of increasing headache, nausea, vomiting, and obtunded consciousness, of course, that makes it easy for you to decide that you need to do something about relieving the CSF pressure, whether the kid has a shunt or not. You need to do something about the case. However, atypical symptoms are often overlooked or misinterpreted. They can be a squint that is absent or better when the shunt is functional. It can be changes in behavior, and it can be an intellectual decline. And very often the parents will be able to tell you that this is the history with previous shunt dysfunction. And although the symptoms aren't typical of elevated ICP, they still indicate that something is wrong with the shunt. Can children have chronic hydrocephalus? Well, yes, of course they can. And the symptoms of chronic hydrocephalus in children is a developmental delay, motor clumsiness, and cognitive symptoms. As you can see, that is a combination of cognition and motor symptoms, which I sometimes in my mind call a pediatric kind of NPH, because they don't have a very elevated pressure, but they do have chronic symptoms that somehow remind you a little bit of the NPH symptoms in adults. So the emergency strategies that we have are actually listed here. You can do imaging, you can do a shunt tap, you can consider shunt surgery, you can consider an EVD or externalization of a shunt, and you can consider an ETV. And of course, you shouldn't do all of this at one time, but the image can guide you. If you have obvious symptoms of elevated ICP and shunt dysfunction, and imaging may be also showing a disconnection of the shunt, and you have symptoms of elevated ICP, then of course it's okay to do an emergency shunt revision procedure, and if the symptoms are severe, then it's needed even in the middle of the night. It's important to say that you should do a systematic troubleshooting of the shunt system. If you find one fault in the system, for instance, a blocked ventricular catheter, that doesn't mean that it's the only thing that is wrong with the shunt system. There can be other things, and the combination, for instance, of blocked ventricular catheter and debris in the valve is not uncommon. So you need to troubleshoot every section of the ventricular of the shunting system, from the ventricular catheter via the valve and to the distal runoff. If you are in doubt, you can always do a shunt tap. The shunt tap will tell you whether the ventricular catheter is patent. If you can suck out CSF, the ventricular catheter is patent, and that will give you an immediate pressure relief of the CSF. You can also obtain in that way CSF for analysis, which will tell you if there is a shunt infection. If you have a shunt infection, then the question is whether to remove the shunt. If it's clearly infected, you need to remove it, and very often need to substitute with an EVD. If you're uncertain about that, you can externalize the shunt, which means that you can take the distal end of the shunt out percutaneously, for instance, behind the ear on the abdomen, which means that you can preserve the proximal part of the shunt, and you can get some time to think when you have externalized the shunt. You can get more data to see if the shunt is actually infected or not. If the shunt is infected, then you can remove it at a later stage and maybe put in a clean shunt on the other side. Please always keep it at your back of your mind that you should always consider whether a shunt could be substituted with an EVD or with an ETV. Try to think out of the box. There is a tendency, if a child has a shunt, then there's always a shunt. But that's not necessarily so. Even with a previous shunt, you can sometimes convert the solution to an ETV. And if you don't have a previous shunt, you can also estimate if this is a child who would be better off with an ETV than with a shunt. I suppose most of you know the ETV success score developed by Kulkarni et al. The success score gives you a percentage success rate for an ETV, which is strongly dependent on age, somewhat dependent on etiology, and whether there's been a previous shunt or not has a minor impact on the success rate. So for instance, if you have a child who is more than 10 years old, you get 50 points. If there is an aqueductal stenosis in the child, you get an additional 30 points. And if the child has had a previous shunt, then you get 0 points. So a child like that would have 50 plus 30 points. That would be a success rate of 80% to change the shunt into an ETV in this situation. So if you can see a point of obstruction, which is what was meant with this, if there is an MMC, if there is an aqueductal stenosis, tectal tumor, or other visible etiology like these, then you have a chance to change the shunt into an ETV. For instance, if you have an aqueductal stenosis, if you have posterior fossa obstructive etiology, like in this case of a Dandy Walker and secondary hydrocephalus to that, or if you have an intraventricular cystic component creating, for instance, like this in this case, a bilateral foramen of Monroe blockage. These will be types of cases that you see in younger children, obstructive cases of hydrocephalus in younger children. In older children, you sometimes see a tectal plate tumor or a posterior fossa tumor, or like this case where you have an overshunting on one side leading to a distension of the other side of the ventricular system, where the change in the midline actually creates a partial foramen or Monroe blockage on the opposite side. And this is a situation that can also be remedied with an endoscopic procedure, with an ETV and a septostomy. But are these emergency procedures? What do you do if you can't do an ETV or an endoscopic procedure at night? Well, then you can always consider an EVD, because if you place an emergency shunt in these situations, you may actually preclude the possibility to do an ETV or an endoscopic solution later, because you reduce the ventricular system so much that you can't pass an endoscope. So Very often in these situations, you can have an EVD as an emergency and temporizing procedure, and then a more permanent solution can be sought during daytime hours when there is a much better opportunity to think and compare images and get a rational look at things. Alrighty. Adults. Well, in this perspective here, when you exclude IIH and INPH, adults can probably divide it into adults who have had their hydrocephalus since childhood, and they've been treated for their hydrocephalus since childhood. Or you can have adults who present with de novo hydrocephalus, but it looks as if it is an early acquired or even pediatrically acquired hydrocephalus. And then there are adult types of secondary hydrocephalus. Let's take a closer look at these. Pediatric hydrocephalus is known since childhood. These patients usually have a VP shunt already. So the first thing you want to do in case of presentation of shunt malfunction is to check what kind of valve type they have. Look if check if the valve has the intended setting, and if it doesn't have the intended setting, then maybe you can just solve the problem by resetting the shunt. You will, in case that is not the case, you will need imaging of both of the brain and the shunt to see if there's signs of over and under drainage or whether there is discontinuity in the shunt system. Again, you evaluate if there are clear symptoms and history of elevated ICP and obvious imaging of acute hydrocephalus. Then, of course, you have an emergency which requires either a shunt revision or consideration of converting to an ETV. If you're in doubt, and if it's estimated to be safe, then sometimes it's wise to defer the decisions to do anything, revise or change strategy until the daytime. So which cases are these? Well, these can be the cases, for instance, who only have a headache or maybe have a headache on top of a chronic headache. These can be the cases who have had multiple shunt surgeries previously, as opposed to a few or maybe only one previous shunt surgery with obvious symptoms. They probably belong up here. But patients with only headache, multiple shunt surgeries, very often, if they have surgery from trainees or junior personnel at night, then the valve is changed just in case, and there is no fault found on the system, and you change the valve because you didn't know what to do, and that won't help the patient. So in these cases, when you have non-emergency symptoms, there's actually time to consider the indication, time to consider change of strategy. Should that be an ETV? Does the patient need the same shunt? Does the patient need a change to another valve? Or does the patient even need an ICP monitoring to see if there's an ICP problem at all? You can go back and compare the scans. If there are scans comparable to a situation when the patient was with a stable functioning shunt, that can give you an indication whether there is a change from that scan and whether action is needed or not. You can always, if you're in the middle of the night and don't know what to do, again, you can always consider a shunt tap to gain time. That will give you a lot of information, same as in the kids. You can detect a blocked ventricular catheter. You can diagnose a shunt infection. And if the ventricular catheter is functional, you can also assess the effect of acute CSF release via a very simple procedure, and you haven't done anything to disturb the shunt otherwise. So the emergency strategies, unsurprisingly, are the same as in older children. You can consider a shunt tap. You can consider shunt surgery if it's obvious clinical symptoms and obvious imaging. You can consider an EVD as a rescue or as in case of shunt infection, or you can consider an externalized shunt. Again, try to think out of the box, see if this patient could possibly benefit from an ETV instead of a shunt revision. You can't use the ETV success score because it's age independent, but you shouldn't be afraid of cases that have had a previous shunt if the case looks amenable to an ETV and there is a visible point of obstruction. So who are the patients with a probable pediatric or early onset hydrocephalus? These are the cases with so-called LOVA, long-standing overt ventricular megaly in adults. These are patients who can have an aqueductal stenosis that has been previously unrecognized, or they have points of obstruction from the fourth ventricle outlets, which have been previously unrecognized. If you ask the patients meticulously, very often you will find that they have slight and unrecognized symptoms since childhood in terms of being cognitively behind and with motor symptoms like clumsiness, and some of them then develop in adulthood NPH-like symptoms, but differently from NPH, they will very often also have additionally some headache. The ventricular morphology in these patients looks congenital. It doesn't look like the regular NPH because the sulcal pattern is more compressed. The ventricular system is out of proportion large compared to the relatively compressed surface of the brain. And you can sometimes also actually see the point of obstruction in terms of an aqueductal stenosis, or as in this case, the CSF flow stops here right at the outlet of the fourth ventricle. These cases usually benefit from an ETV and can be deferred until daytime. De novo hydrocephalus in adults quite often present with emergency situations. That can be a blockage like a colloid cyst. And if you have a colloid cyst blockage, very often the ventricular system hasn't had a chance to become very large. It's very often an acute blockage with severe symptoms of elevated ICP. And the obvious solution to that is endoscopic removal of the cyst. And if you can't do that, then don't put in a shunt, put in an EVD, and defer the case for daytime surgery, where somebody who knows how to can pass an endoscope and remove the cyst. Cerebellar mass lesions, for instance, with a small volume of the posterior fossa and an expanding lesion in the posterior fossa, you very often develop secondary acute hydrocephalus. Of course, these cases need emergency evacuation of the cerebellar hematoma, but they also need an EVD to alleviate the hydrocephalus. If the hydrocephalus persists, in these cases, you can actually consider secondary to perform an ETV. There are also other causes of hydrocephalus with visible obstruction of the CSF pathways. The most frequent one is hydrocephalus secondary to subarachnoid hemorrhage. And these cases, as with this obvious dilatation of the ventricular system, of course, need an emergency EVD to deal with that. That's pretty simple. So de novo hydrocephalus in adults with high pressure symptoms are usually secondary to other and pretty obvious causes and lesions. And very often they go on to develop secondary chronic hydrocephalus with a need for a shunt or a need for an ETV. So what have we done now? We have defined key types of hydrocephalus: infantile, pediatric, and adult. We have reviewed essential imaging and clinical features. We have outlined basic management principles, which are rather diverse, and we have highlighted at least some common pitfalls and some suggestions for alternative thinking. We have offered some practical guidance on which options you have to do, can make use of in an emergency situation, and also hopefully which situations you don't have to necessarily do surgery as an emergency in the middle of the night, how you can create a safer situation with temporizing measures, and also sometimes recognize that the situation maybe is not as acute as you thought. Okay, these are the words for now. Thank you very much.
Thank you so much, Marianne. This was a great start, and I think we have a huge audience, which is just showing the tip of the iceberg how interested people are in this topic, getting ready for the shift and getting ready, hopefully, to join the CSF section as well. And with that, I think we give you a short break until we start into discussion. I would like to remind the audience to put questions into the Q&A section. Please use that. Put your questions in there right now before we go to the second part of this webinar. Mukesh, would you like to take over here?
Okay. Would it be possible to ask two questions for pediatric hydrocephalus, because we're switching now to adults? One question is it's a case, a 4-year-old child coming in the emergency room, have vomiting for 3 or 4 weeks. And they do an MRI and see a posterior fossa tumor. It's a very typical situation you face often in the emergency room. And what you do with the hydrocephalus? You can schedule the operation for the posterior fossa tumor the next day when you have new monitoring and so on. So, but what is your recommendance for the hydrocephalus? Doing an EDV or do nothing, wait to the next day? The only symptoms are vomiting 3 or 4 weeks.
Well, as you say, there are several options, and it's actually debated what to do about hydrocephalus in case of fourth ventricular tumors in children. In some departments, they do an ETV, which stabilizes the situation, and then you can wait a couple of days or maybe a little longer. In other cases, people prefer to remove the tumor as the first option and then see if the hydrocephalus resolves that way. And if it doesn't, then put a shunt or an ETV at a later stage. I would think if the child has only vomiting, no headache, and is cognitively and behaviorally completely clear without any signs of decreased consciousness, it is actually possible that the nausea and vomiting could be because of proximity to the posterior part of the brainstem with the area postrema, and if that would be the only symptom, I think if the policy of the department would be to do tumor surgery the next day, I would consider that to be safe.
Okay, thanks a lot for the great answer. So the second case, it's the nightmare of every trainee. You have a patient with multicystic multi-compartment hydrocephalus. He has one catheter on the right, one on the left, and one in the fourth ventricle. And he had a fulminant meningitis. So as a trainee, you have to put out the shunt because it's a fulminant meningitis. But what do you put in? Do it all 3 catheter in to put 3 EVDs, or what's your recommendation about that?
Wow, you really got me there, right? Well, multilocular hydrocephalus is usually the result of bleeding or infection, and the infection can be either parasitic or bacterial. So one of the things that can be done is actually a preventive measure, as I said before. If you do endoscopic lavage before the multicystic situation develops, then you get much less multi-compartment hydrocephalus. But that is already too late because the child already has this, and you have an active infection in the CSF. I think you can still consider unifying the compartments. I would still recommend that, even in an active infection, and that gives you the chance to get a single runoff through one EVD. And that would also tell you whether you had actually unified the compartments enough, because if you get a reduction of all compartments and a runoff through a single EVD, that would tell you that later you can get away with a single-stranded shunt. And I would go pretty far, even repeat endoscopic procedures to obtain that.
Well, thanks a lot. So now I have the honor to introduce Lawrence Watkins. Lawrence Watkins is a consultant in neurosurgery at the National Hospital of Neurology and Neurosurgery in London, and he is a recognized expert in hydrocephalus, intracranial pressure, and neuroendoscopy. And he has over 80 publications in this field. And he was the past president of the International Society of Hydrocephalus and CSF Disorders. And he's also the director of the London Neurosurgical Training Rotation Program, one of the largest training programs. So he is particularly interested in training neurosurgeons. And then I'm very pleased that he is given his expertise and time today to talk about shunt strategies in NPH and IIH patients. Thanks a lot.
Thanks, Mukesh, for that lovely introduction. And thanks to the EANS for the invitation to speak today. So I'm going to try and share my screen and we can deal with slightly more specialized adult topics. Okay, so I've been asked specifically talking about the adult conditions of intracranial hypertension and normal pressure hydrocephalus. And this is part of the overall series idea to teach people the basics of hydrocephalus, what you need to know. And as Mukesh says, that's where I work at the National Hospital in London. These are my potential conflicts of interest. So just to put this in context, the most common things that you're likely to come across, particularly in a clinic or an acute situation, are these 4 types of adult hydrocephalus. And I'm going to concentrate on intracranial hypertension and normal pressure hydrocephalus. The thing that they have in common is that they're communicating forms of CSF dynamics, and therefore tend to be more slow moving, less likely to lead to acute damage. Unlike things like a young person who's got a shunt, has had a shunt since infancy, if their shunt blocks, they may be totally dependent on the CSF drainage of their shunt and can get into trouble very quickly if they have an obstructive type. And new onset obstructive hydrocephalus, like we saw just now with colloid cyst, is one of the classic ones, where somebody goes from a normal physiology to suddenly having a blockage in their CSF flow. And both of those things can be very serious and need to be dealt with, usually acutely. I think the difference is that where there's an obstruction, you can get a shift in tissue, and it's not the absolute pressure that usually causes the damage, but the shift between compartments, because tissue gets distorted, and that's what causes the most damage. You can have a relatively high pressure inside your head and not come to any harm if it's equal in all parts of your central nervous system. So it's the shift that causes damage, not the absolute pressure. And so the two things that I'm talking about, IAH and NPH, are by definition communicating. And so that's the first thing to understand. Just to give a refresher for normal pressure hydrocephalus, this is a condition typically in people over 65. It's characterized by gait and balance disturbance. That's usually the primary presentation, but can also have cognitive decline and urinary urgency. As I say, it is by definition a communicating CSF disorder, and it has to have large ventricles. There are many videos on the web, but I'll just show you one. But if you're not familiar with it, it's usually people who are very unsteady, like this lady, difficulty with turning on the spot, very small steps. You can think of it psychologically as they think they're going to fall at any minute, and so they're not willing to commit themselves to large strides. This is the same lady a few weeks after she'd had her shunt, now down from 2 white coats helping her, down to just her husband keeping an eye on her. And then 6 months later, a dramatic improvement. So the thing about normal pressure hydrocephalus is that it can have dramatically positive results and therefore is worth recognizing. The gait tends to be wide-based, short steps, increase in foot angle, that's the angle, the feet are no longer parallel with each other, but tend to be pointing away from each other. Magnetic, as if the patient's stuck to the floor, and freezing, so that they can be seemingly in their stride and then suddenly come to a halt and can't move for a few seconds. We're always on the lookout for other pathology, so getting the patient to lie on their back on the examination couch and pretend to pedal a bicycle in the air. NPH patients can do that because they have no ataxia and they have no focal deficits. This is an apraxia, cortical communication problem, which means they can't put the patterning together to construct a fluent gait. But everything else is working, so they should be able to do that bicycle test. They shouldn't have any pronator or postural drift. Their eye movement should be essentially normal, apart from perhaps loss of up gaze, which can even be normal in people over 65. And they should have a normal head circumference. There are Bushby criteria, which are very similar to the head circumference charts you see in pediatric wards, but this is for adults looking at head circumference against their height. And if they're way out of the normal range, then they've probably had their hydrocephalus for a long time. And that's therefore likely to be long-standing avert ventricular megaly in adults, so-called LOVA, rather than NPH. From a neurologist's point of view, and we have some neurologists on the panel, so they'll tell me if this is true, but one of the most common ways of spotting it is if you have a levodopa unresponsive gait apraxia. So they're typically people turning up with, have they got Parkinson's, but they don't quite fit Parkinson's and they don't respond to levodopa, and you start thinking, if they have ventricular enlargement, that maybe this is another condition. And so that would be the way of looking at it from, and this is where we get a lot of our referrals, is through movement disorder clinic. The diagnostic test, you want brain imaging to look at the aqueduct to make sure that it's not an obstructive hydrocephalus. And we also typically look at the spine as well, because hydrocephalus can be secondary to a spinal canal stenosis or obstruction with a tumor. So you never want to assume that just because somebody has hydrocephalus that it starts in the head. It can actually be secondary to a spinal abnormality. Typically in normal pressure hydrocephalus, you get a pattern called DESH, which rather awkwardly stands for disproportionate enlargement of subarachnoid space hydrocephalus. And it's characterized by disproportionate enlargement of the sylvian fissures, but relative effacement of other fissures. So you get crowding of the sulci near the vertex. So this is a coronal picture of the typical DESH, and you can see that the sylvian fissures are very enlarged, but looking up near the vertex at the top of the head, you can hardly see the sulci. And so not all the cells are proportionately enlarged, they're disproportionately affected. And the other thing, this callosal angle, the angle of the tissue between the two, when judged at near the back of the third ventricle, is an acute angle rather than an obtuse angle. That suggests a hydrocephalus rather than some other form of neurodegeneration and atrophy. The diagnostic test, the classic, is the extended lumbar drainage protocol with a lumbar drain draining for 72 hours at approximately 10 mils per hour is the sort of standard starting point. There are various pumps like the LipoGuard and the Selda that can be used, and you look before and afterwards for a measure of whether the patient has improved. Walking tests, of which the two most commonly recognized are the 10-meter timed walk and the timed up and go test, where you get up from a chair, walk around a bollard 3 meters away, and then go back to your chair and sit down again. You can do cognitive assessment, particularly if the patient has a particular cognitive presentation, and urinary diaries can be useful of how frequently patients are getting up and what time of the day and night. After their lumbar drain, the benefit, if they have any, is can last a week or two, so it's useful for them to keep a journal once they're home and they see how they perform in their home environment. The other thing we do is during these initial tests is look at biomarkers, tau and amyloid beta and the various phosphorylated taus to see if they are suffering from another disease in parallel. Then there's the infusion studies, which you do with the patient lying flat so that all of their CSF is at the same pressure, and use an infusion pump and see how much their CSF pressure goes up for a particular level of infusion. So, and if you have a higher, you can calculate the CSF outflow. And if you have a high CS outflow, it's more likely you're going to benefit from a shunt. This is data from our National Institute for Health and Care Excellence. This is a sort of exam question that comes up. The units that you measure that in is millimeters of mercury per mil per minute. And the way I think of that is if you're infusing 1 mil per minute in an infusion study and your pressure goes up by 1 millimeter of mercury, that's 1 millimeter of mercury per mil per minute above whatever their baseline was. Now, this condition you're going to see more of in future years. If you're in practice and seeing hydrocephalus patients, which is all of us, then the structure of the population is that we're getting more and more people over 65. This is the data specific for the UK, but most developed countries are facing a similar population bulge who are soon going to be in their 70s and 80s. And since the incidence of this condition goes up exponentially, that means that we will be dealing with this condition increasingly in the future. Now, the second thing that I'm talking about, intracranial hypertension, that's also going up, probably due to obesity. And we can see that these dotted lines are the increase in percentage of obesity in our population. It's going up both in males and females, but the incidence of IAH is going up disproportionately in females and not so much in males. So we think there's almost certainly a hormonal aspect to this as well, but the incidence is definitely going up. It's very much more prominent in women and typically between 20 and 50. The management of this condition, although I'm a neurosurgeon, I've got to say that most of them are managed medically, and we mustn't forget that most of them are medically managed by things like acetazolamide, for example, and only a relatively small proportion end up needing a shunt. Most of them can be managed medically. The typical presentation would be with headaches and worsening peripheral vision. You see intracranial hypertension indirectly by looking for papilledema and visual field loss. You would check on imaging that they haven't got a contraindication to lumbar puncture, such as a bad Chiari obstructing their foramen magnum. And on a lumbar puncture, they would have raised CSF pressure, typically above 30. That's a pretty definite case. Some people would accept above 25 as diagnostic. And you want some form of imaging of the venous system, because if there is stenosis of the venous sinuses, that can be a cause and a correctable cause. So if you're assessing somebody with this condition, possibly you look for papilledema like this. That's very bad papilledema. And the options that you've got are acetazolamide, weight loss if you have more time, lumbar puncture or lumbar drain. And the lumbar drain is something that some people forget. You can temporize even on a bank holiday weekend when you know you're not going to be able to do anything definitive. You can put in a lumbar drain because this is a communicating condition once you've done the imaging to exclude that it's not a communicating condition. And there are options for medical management, as we said, acetazolamide being top of the list. And if you have rapidly deteriorating vision, you would want to put in a lumbar drain, temporizing until you can either put in a shunt or a stent. So this is the typical algorithm, which I won't go through today because we've only got a limited time, but this is the one in use in our group of hospitals, for example, showing the other causes such as severe anemia can lead to intracranial hypertension, and that is of course correctable. And renal issues, sleep apnea, all of these things you have to think about. And most of these things are going to be managed by a neurologist and or ophthalmologist. But if you have fulminant, i.e. rapidly deteriorating vision in this condition, then usually you need to include the neurosurgical team to put in lumbar drain and then eventually consider either stenting or shunting. This is a catheter venogram, and the pressures inside the sagittal sinus dropping down as they usually do. But then suddenly when we reach this part in this particular patient, it drops from 15 to 8. So there's a definite stenosis at this point. And if you've got a limited stenosis, then in addition to shunts, you also have the option of putting in a stent. And so, a patient with a definite limited stenosis, you can stent the condition. And there is a multi-center randomized controlled trial in process at the moment, seeing which of these two strategies is going to be the best. The other trick is looking for radiological markers of raised ICP. So even if you're not going to do ICP monitoring, you can look at their radiology and the things that you can see on a typical MRI, rail tracking, where the arachnoid sheath of the optic nerve is expanded, and so you see this sort of rail tracking pattern. Sometimes you can even see the bulge of papilledema on an MRI scan. If you're looking particularly at a sagittal, you can see tortuosity of the optic nerve, and again on a sagittal you can usually see an empty cella. None of these are definitive in themselves, but if you have a conglomeration of all three or 2 out of the 3, it makes it much more likely that the patient has raised intracranial pressure. And then looking at ophthalmological signs, apart from papilledema, you can also look at what I've highlighted here, venous pulsations. So just to play that again, venous pulsations are normal. You should be able to see venous pulsations. If you lose them, that's a pretty reliable ophthalmological sign of raised intracranial pressure. So that's a good trick that you can learn if you get used to looking at people's retina. For those who have got any of these conditions, if you've got suspected shunt malfunction, you can look for, in the context of NPH, you would be looking at their triad features. You would suspect it if they've been doing extremely well following shunting, and then within a week or two, they deteriorate back to their baseline. The first thing that comes into my head about that condition is that maybe their shunt has malfunctioned, because typically that's a slow moving, slow improving, slow deteriorating condition. And so have they changed? Walking test, cognitive assessment, urinary diary. Interestingly, if you've got one thing improving, but another thing deteriorating, like, for example, if their walking test much better, but they say their urinary function has deteriorated, it's probably not to do with their hydrocephalus. And you'd be thinking more, have they got a prostate problem, for example, or something entirely different? So all of the triad things should be moving in unison for it to be blamed on their hydrocephalus. There are ways of doing non-invasive ICP monitoring. This is something to be aware of in case you see one coming into your department. There are various types of, this is an MSIO, for example, a chip inside the reservoir means it can be interrogated non-invasively. So if you have that option, that can be a way of assessing shunt malfunction. Both of these conditions, IAH and MPH, you do a CT scan, and usually it's completely unchanged, and that doesn't tell you anything, because usually the ventricular size doesn't change in these conditions, whether a shunt is blocked or unblocked. So the ventricular size, not very helpful in assessing the situation. Why we do the scans is usually looking for other things, as in this case, an associated subdural in combination with a shunt. So the ventricle's unlikely to change, but we're looking for other things. Have they had a subdural development, or have they quite randomly had a cerebral infarct, quite apart from their original diagnosis? And we would also do a shunt series, that's just plain X-rays, looking at the tubing along its length to make sure it hasn't broken or fallen apart at one of the connections. On MRI, particularly, this is a T2 high resolution MRI, you can sometimes see the debris inside the catheter and the blockage. And so that's one other way of diagnosing a blockage. You have to do the plane of the MRI in the plane of the catheter to get a good view of it. And then we were talking about the diagnostic tests. One way of looking for blockage of the shunt in NPH is just to repeat the tests again, do a tap test or extended lumbar drain. Because if they improve again, it means their shunt's not working well enough. So they still have the potential for improvement. So that can be an indirect way of diagnosing that they have a problem with their shunt. Infusion studies are another way of testing. We talked about them in the context of diagnosis, but you can also use them to test shunt function. So most shunt systems can take 2 or 3 mils per minute of CSF. That's way over the physiological absorption rate. So if you have a patent shunt, your R out should be low, even lower than physiological. So if you have a shunt in place with any of the common systems and your R out is still high, you know the shunt is not behaving properly. And ICP monitoring gives this sort of typical 24-hour pattern. And if you have the facilities to do that in your department, that's another useful way of assessing shunt function in all of these conditions. But you have to have the facilities to do it and record it, and enough of a database to know what's normal in normal range in your context. The other thing that is a useful trick that we sometimes use is a shuntogram, which is very much like a linogram for checking patency central lines. And you get pictures such as this. You're injecting a contrast dye into this person's shunt, and you can see distal contrast and proximal contrast going from the reservoir. I thought this was a good picture because it shows some tubing on another shunt that the patient also had in. That's what a contrasted tube looks like. That's what an uncontrasted tube. You can't really mistake the two because you can see the contrast within them if you're doing them in a digital subtraction angiogram suite. That's where we do our shuntograms. And if you've got a blockage like this one, you can see it going so far, but not out into the ventricles, and nothing at all is going down through the shunt valves. This person had a completely blocked ventricular catheter and valve. So you just see a little column of contrast. And when you're doing them live in the angio suite, you can see the CSF pathways in great detail. So this is a typical live video. You can see it going down the ventricular catheter, out into the ventricles. You can see it going distally. This person had quite a complex shunt system. And in addition to showing that all of it is patent, we can also see a small leak coming out into the tissue. So this person had a leak at a connection point in their system. So shuntograms are very useful adjunct. And I would say they're very useful if you can get used to doing them in your department. You have to have very good aseptic technique, of course, and you can use any of these types of omnipaque, but know that there are some forms of omnipaque that are not for intrathecal use. So typically I would use the omnipaque 240 as a contrast medium for this test. And don't try and do them with static X-rays. It's very unedifying. If you do them in the angiographic suite, you get those beautiful pictures that I just showed you. Thank you. I think it's almost time for our discussions. And I would recommend that everybody who's interested in this kind of thing and in neurosurgery in general, don't forget to attend our Congress in Vienna in October. We're all looking forward to it, and there will be special sections on hydrocephalus, so it should be extremely exciting, at least for me.
Thank you so much for this wonderful talk and the reminder for Vienna. I think that will be a great meeting with a pre-meeting for a special interest in hydrocephalus. I think you will present again on shunting. Marianne will be there. A lot of other people from the CSF section. Susan Mullen will share about IIH. So this will be firsthand, again, basic knowledge, how to start, and the pearls and pitfalls of the experts, like you, the two of you. So thank you for sharing. And since I just took the liberty of starting, I would really love to pose the first question. Again, coming from the neurologist, seeing a lot of IIH as well and NPH. What can you maybe like a little bit explain about the pitfalls of measuring the opening pressure in lumbar punctures?
Yeah, although it is the absolute standard of doing a lumbar puncture pressure because it's easy essentially to do in most departments, but you can be misled if the patient has got their knees too close up to their chest, or if they're very tense, or if they're breathing abnormally because they're under a lot of stress at the time. You can get a very different answer from the same person just by straightening their legs out, for example. So that's one of the major pitfalls. And if we're considering surgical intervention, that's why we tend to do intracranial hypertension as being 24 hours of data, much less likely to be misled by that than by a single reading from a lumbar puncture. So a lumbar puncture can be useful in a emergency department scenario for getting some idea if the pressure is very high, and also it gives you the chance to reduce it if and that again is a temporizing maneuver. And for a lot of, if you're going to medically manage them, that's sometimes enough to establish the diagnosis. If they've got papilledema and a high CSF pressure, you can try their acetazolamide and see if they're going to improve. But if they're in that 7 or 8% that end up requiring surgical intervention, I would be in favor of doing ICP monitoring as a more definitive way of getting baseline data.
Thank you so much. I think especially we get so many wrong elevated pressure measurements. Just take the time, let the patient breathe, stretch the legs. It's so crucial, and yet often it's mistaken.
Yeah, it's you can have the same patient having the same lumbar puncture, and even during the time that you're measuring it, it can be changing visibly. So you think, how good is this as a snapshot?
Could I just add that there's actually publications on the effect of different posturing during lumbar puncture, how much that can change the ICP. And one of the things that is overlooked is actually whether people have extended or flexed the head, because flexing the head actually causes a significant increase of the measured pressure. So you need to have the patient extended with both head and legs to get reliable measurement, and you also need to standardize it so that when you do several punctures at intervals, for instance, to see treatment response, you need to make sure that the patient is in the same posture each time.
Apart from,
I think that publication came from a very, very talented neurosurgeon I know.
Oh, really?
It was Marianne's group doing that.
absolutely, I thought that's why Marianne was telling us about it. But the other thing is twisting the neck. If you look off to one side, like if the patient's trying to see what you're doing behind their back, that also puts up your CSF pressure. So yeah, there's lots of things that you can cause misleadingly high pressure if you're not paying attention to the specifics.
There's one interesting question when from the audience. When you have a colloid cyst and you don't want to do the endoscopic procedure in the night and you want to put an EVD in, right, left, or both sides, because there's a blockage of the foramen Monroe.
In colloid cysts, the answer is it's safer to do bilateral, and that's the textbook answer, because then you're safe. But I've actually seen cases where they put it in unilaterally and it seemed to work as well. So I think it depends on the exact specifics of whether there's any flow between the lateral ventricles past the cyst. But it's just the third ventricle posteriorly that's been blocked by the cyst. But the safest thing is to put in bilateral frontal EVDs, and that would be the textbook answer.
Sometimes one of the ventricles is considerably larger than the other, and then you can safely put in on that side alone. But otherwise, I completely agree that the completely safe solution is to put in a bilateral EVD, and that wouldn't preclude the subsequent access with an endoscope. So that's fine.
In fact, it's almost certainly the right thing to do if it is early hours of the morning, is to put in EVDs and then do an endoscopic procedure, which can be technically challenging during daylight with the full team and the right equipment.
Exactly.
I think there are two questions. I will try and summarize them. I think they are actually posed to you, Marianne. There's a question about the outcome or the prediction of the success rate of ETV in adults. So is there something that you can say about this, and how is it compared to children? And also there is another question in the chat in the same direction, where they just had a very bad outcome because the patient developed a meningitis, I guess. So maybe the connection of infection success rate in the adults. Can you comment on that?
Well, I'll start off with the ETV question, and actually, we have a large Scandinavian cohort of 1,500 patients, which we hope to be able to publish pretty soon. It's taken rather long, much longer than we liked, but the statistics have been done, and it turns out that age is not a predictive factor. We had actually thought that success rate might decrease with age because you might have increasing absorption problems with age, but that turns out to be not the case. Etiology is not dependent either, but visible obstruction is a high indicator for success rate, and also whether you have had a shunt or have not had a shunt previously actually also has an impact on the ETV success rate in adults. So these are the two things that stand out after a multivariate analysis that stand out as significant indicators of success rate in adults.
Yes, I'll look forward to seeing that paper, Marianne. I don't think it's out yet, but my practical view is that very similar to the childhood table that you showed us, sort of if you're over 10, then it's like 50% added. And if you haven't had a shunt before, that's 10% added, which gives you about a 60% chance of success. And that is roughly in keeping with our experience here in London as well, that it's about 60% chance in adults. So it's like a over 10-year-old child who hasn't had a shunt.
That's not a bad rule of thumb at all. But you can pick out cases where the success rate is considerably higher, and also ones where it's considerably lower.
So I think another consideration is not just if you've got a 60% success rate, but how acceptable is that? If somebody has an acute condition which is dangerous to them, do you want to do an ETV that has a significant chance of 30 or 40% of not working when you know that shunts have 99%, at least in the short term? So you have to judge it on the basis of the individual. How critical is it that their CSF drainage is established again now? And if you can't really afford to take the failure rate of an ETV, then it's safer in the short term doing a shunt.
I absolutely agree, but you also have the option of combining an ETV with an EVD if you're uncertain about the immediate relief. Then, yeah. But that
or leaving in a catheter with a reservoir on.
Right. But of course, that would carry a risk of having to put in a shunt secondarily if it doesn't work, and you need to take that up front with the patient and or the family before you decide.
If you've got time to think, which in a lot of these conditions you certainly have, and it's not a disaster if the ETV doesn't work, then it can be well worth considering and discussing.
Well, actually, the only hyper acute emergency is really the colloid cyst with a complete blockage of bilateral foramen of Monnery. That requires immediate action. You hardly have any time to think there.
Yeah.
So Watkins, short question for me. Thank you for an excellent talk. It's about the IIH patients. Do you think that the optic nerve sheath fenestration has a place in the treatment of acute impaired vision in these patients?
I think it varies a lot from unit to unit. It's quite a skill-dependent intervention. And so if you have an ophthalmologist who's very experienced at doing that condition, and particularly if you don't have any other good options in the unit that you're in, then it's still within the spectrum of acceptable practice. However, a lot of ophthalmologists have gone off that idea because there is about a 1% risk of causing complete visual loss in the optic nerve that you operate on. This is presumed to be due to vascular interruption. And so you can infarct the whole retina as a potential risk of doing it. So a lot of ophthalmologists say, well, if you've got shunts, which is a very high rate of protecting vision and a very low rate of complication comparatively, most of them would prefer you to do that if it's an option that's available in your unit.
Absolutely, I can relate to this as well. I think there is another more specific question about ETVs again, probably to both of you, whether you would consider combination of cauterization of the choroid plexus in combination with the ETV.
Well, that is an option that was initially coined by Benjamin Worf, who did some work in Africa with ATVs on infants and combined it with choroid plexus cauterization in order to reduce the production of CSF. A lot of the work from Africa is not it has not been able to repeat the same type of success rates in other settings. And I think the eagerness to combine with choroid plexus cauterization has somewhat diminished. We don't do that because we think that you need the choroid plexus. It has a physiological function other than just producing water. It probably also has a nourishing and distribution of signaling molecules throughout the CNS. So we think it probably is could be unadvisable to do that. So I think you get a lot of answers from different answers from different people, and no clear indication whether this actually improves the success rate of ETVs or whether it doesn't in small children. I don't know anything about adults in this perspective, but maybe you do, Lawrence.
It's technically a much longer operation if you're going to do all the choroid plexus coagulation as well. And I think you're quite right, Marianne, that it depends on the context. If you're doing it in an area, as Ben Worf was, where the shunts were in short supply, where you did have endoscopic equipment, and also where the baseline infection rate is very high by most of our unit standards, that's a completely different situation to be recommending it than for one of us to be doing it. Choroid plexus coagulation doesn't really add much to an ETV, certainly in the adults. The ETV is either successful or it isn't, as we were discussing just now, but the choroid plexus coagulation doesn't seem to add very much. And I, like you, would be worried because we know that the choroid plexus has a very important physiological role. There is a whole bunch of biomarkers and nutritive factors that come through the choroid plexus. And one of the things that we're learning from the basic research is that the choroid plexus barrier is entirely different to the blood-brain barrier. So there are many things that find their way into the brain tissue through the choroid plexus and into the CSF. So it's not just water. The CSF is doing a lot of important functions, some of which are being done by the choroid plexus. So if we don't have to do it, I think it would probably be something to be avoided in our patient groups anyway.
So there's one question from the audience regarding posterior fossa mass lesion in an emergency setting with a concomitant hydrocephalus. When you're putting an EVD, how much is the risk of upward herniations, and have we be scared about it?
Probably the risk is lower than is thought. But I don't think any of us would recommend just putting in an EVD in case of a posterior fossa mass lesion. We would recommend adding an EVD to the decompression of the posterior fossa.
Yeah, I agree, Marianne. And in adult practice, it's more common for people to have a posterior fossa hemorrhage, for example. And this worry is always, if you treat the associated obstructive hydrocephalus, will they get upward herniation? It must be rare because we're a huge center, and I've never seen it, but it is a theoretical risk. But what you would do is decompress the posterior fossa and put in your EVD to treat any associated hydrocephalus.
Thank you for both for your elaborations. Torbjörn, did you find something? I think we have a lot of discussion going on in the chat on the side, agreeing a lot to what you say. I see.
I can say there's one question concerning experience in CSF flow imaging in NPH.
There is some evidence that you can look for aqueduct hyperpulsatility. So that's a way of looking at CSF flow that would be relevant to INPH. And you can sometimes see that on a sagittal T2 because you get a flow void through the aqueduct. And if it's very pronounced and you can see that flow going back and forth into the fourth ventricle and up into the third ventricle, you see a little plume of signal void. That is often associated with null pressure hydrocephalus. So that would be, and that has been attempted to be measured by radiologists and with some success, looking at that as an indirect measure or diagnostic adjunct in null pressure hydrocephalus. But on its own, I don't think you could put enough weight on it to be guided in clinical practice. But it is something that is observed.
And just the last follow-up questions, Dr. Watsons, for that. When you do have a patient with NPH, do you have any clinical rule of thumb, which of these three symptoms that may improve after shunting, which most likely to improve?
Yes, I think pretty much in the order that I said them right at the beginning of my talk. The gait disturbances, I would be much more optimistic about improving them. Usually they're, after shunting, for example, they're usually the first to improve and the most likely to improve. And that's also the most likely to be able to be measurably improved after an extended lumbar drainage protocol. Urinary function, next most likely to improve, but it's difficult to unpick whether that's really improving their detrusor instability, which the urologists tell me is the underlying basic problem with hydrocephalus, or whether it's just they can walk faster to the toilet and therefore are less troubled by their urinary problems. And the least likely to improve is if the patient has prominent cognitive decline. That's usually a late sign of the whole syndrome, and also the least likely to improve. And if it does improve, it's the slowest to improve. So pretty much in that order would be a general rule of thumb, and that's how I would counsel the patients of what to expect.
The experience from the memory clinic here in Copenhagen is exactly the same. I can see there is a question about the risk of infection by tapping a shunt. And I would say that if you adhere to sterile principles and do it with care, the infection risk of a puncture is very low. It's not zero, but it's very low. And compared to the information that you can get from shunt tapping, and compared to the emergency relief of CSF pressure that you can obtain that way, the risk is insignificant compared to these advantages.
Yeah, I would say that you should use proper chlorhexidine skin prep rather than just one of the venipuncture alcohol wipes you would do a blood test with. You should do proper skin prep. But if you're doing that, the infection rate is very low, way less than 1%. And if you're going to get useful information from it, I don't think there is much of an argument about the risk-benefit analysis.
Thank you two so much for sharing. There's still a lively discussion going on. I think we have so many starting points for more webinars to follow here. Especially, I took notes on what not to do. A guide for neurologists and neurosurgeons, maybe alike. For a last comment, I would just love you. What is the one thing you don't want to hear from your residents in the next morning in regards to hydrocephalus? What is the one thing everybody in your hospital knows not to say to you in the next morning, what it did to a hydrocephalus patient? Pick any type.
I couldn't find anything wrong with the shunt, so I changed the valve anyway. That is not what I do not want to hear, because it means that you didn't think what was wrong.
Yeah, similarly, I would say we weren't sure, so we revised the shunt. Oh no, don't do that. And the other thing that I never like to hear is NPH. I don't believe in it.
Okay,
so
that's going to be the title of the next webinar, and we can probably talk a lot about NPH and Alzheimer's and overlap, like probably not an hour. But I'm so happy to see there are still more than 90 listeners in the webinar. And of course, it's recorded, so you can find it on YouTube, share it. And we are happy to see you with our next CSF webinars. And with that, I would like to thank Mukesh, Torben, Marianne, Lawrence. It's been a pleasure having you. And so with that, goodbye and have a nice evening.
Thank you.
Goodbye, everyone. Thanks very much.
Bye.